Welcome to our first video on congenital mixed immunodeficiencies. Let's begin. In this lecture, we will go over severe combined immunodeficiency and Wiskott Aldrich syndrome. For both topics mentioned, we will cover its definition, pathophysiology, risk factors, clinical features, diagnosis, and management. At its core, severe combined immunodeficiency is a primary immunodeficiency disorder of T cells and B cells. The pathophysiology of this disorder stems from a genetic mutation that disrupts T cell maturation and function. There is an X-linked recessive variant that leads to a defect in interleukin receptors, which impairs T cell maturation. There is also an autosomal recessive variant of SCID that leads to a defect in an enzyme called adenosine deaminase, or ADA. Without adenosine deaminase, toxic metabolites build up within T cells, which disrupt their function and eventually lead to their death. The overall impairment of T cells, in turn, causes a dysfunction of B cells, which is why this disorder is termed severe combined immunodeficiency. The two primary risk factors for this disorder are male sex and positive family history, due to the fact that this condition can be inherited either in an X-linked recessive or autosomal recessive fashion. When it comes to the clinical features of SCID, all patients will experience recurrent infections that will usually start by age 6 months. The infections can be viral, fungal, or opportunistic in nature, and the more common culprits include Candida, which causes thrush, and Pneumocystis jirovecii, which causes pneumonia. Most kids with SCID will also experience chronic diarrhea, and as a result of recurrent infections and persistent diarrhea, most will also experience a failure to thrive. Lastly, patients with severe combined immunodeficiency also have scant or even absent lymph tissue on physical exam, meaning that these patients have absent tonsils or lymph nodes. Here's an image of a patient with oral thrush due to an infection with Candida. Note the characteristic white plaques on the tongue. How can clinicians distinguish thrush, on the left, from leukoplakia, on the right, on the physical exam? The easiest way to distinguish oral thrush from leukoplakia is to scrape the lesion with a tongue depressor. If the patient has thrush, the clinician will be able to scrape the white lesions off the tongue. If the patient has leukoplakia, on the other hand, the clinician will not be able to scrape the white lesions off the tongue. Remembering this key difference will help you confidently distinguish oral thrush from leukoplakia on exams. In addition to oral thrush, patients with severe combined immunodeficiency are also at increased risk for opportunistic infections. A common opportunistic infection in these patients is pneumonia due to Pneumocystis jirovecii. This chest X-ray is showing the characteristic bilateral ground glass opacities that can be seen in patients with Pneumocystis pneumonia. By the way, another way to think of ground glass opacities is hazy gray areas, or the view one gets when looking at an object through a semi-opaque shower glass door. The diagnosis of severe combined immunodeficiency is usually first detected on newborn screening, which will report an absence of the so-called T cell receptor excision circles, which are circular pieces of DNA that are excreted by developing T cells in the thymus. Clinicians may also order flow cytometry, which will reveal markedly decreased T cell and B cell counts. And clinicians may obtain a quantitative serum immunoglobulin measurement, which will reveal decreased levels of all immunoglobulins, such as IgA or IgG. This happens because an impairment in T cells renders B cells incapable of differentiating into plasma cells and producing immunoglobulins. Lastly, were clinicians to order a chest X-ray, they would likely see an absence of the thymic shadow due to thymic hypoplasia. Consider these two chest X-rays side by side. The chest X-ray on the left was taken from a healthy baby. Note the spine, heart, and this opacity overlying the right upper lung that somewhat resembles a sail of a boat. This sail-like opacity is produced by the thymus. Now, consider the chest X-ray on the right, which was taken from a healthy adult. Note that there are no sail-like opacities in the right upper lung. This is because the thymus normally atrophies once it's done producing mature T cells, which normally happens around puberty. As such, the presence of a thymic shadow is a normal finding in children. Therefore, absence of a thymic shadow on a pediatric X-ray like this would be suggestive of an abnormality like severe combined immunodeficiency. Aside from severe combined immunodeficiency, which additional congenital immunodeficiency disorder may result in an absence of the thymic shadow on chest X-ray of a newborn baby? Absence of thymic shadow on chest X-ray of a newborn may be seen in severe combined immunodeficiency and DeGeorge syndrome. Recall that DeGeorge syndrome has 5 key clinical features that can be remembered with the Catch-22 mnemonic. The mnemonic stands for cleft palate, abnormal facial features, thymic aplasia, cardiac defects, and hypoparathyroidism or hypocalcemia. And the number 22 reminds us that this happens due to a microdeletion on chromosome 22. Bearing these clinical features in mind, newborns with DeGeorge syndrome will not have a thymic shadow on chest X-ray due to thymic aplasia. As far as management of severe combined immunodeficiency is concerned, a stem cell transplant is the only definitive or long-term treatment option for these patients, as it is the only option that may help restore the development of a functional immune system. In fact, if babies with SCID don't get a stem cell transplant, they are unlikely to survive beyond 1 year of age due to recurrent infections. Most clinicians will also consider giving these babies antibiotic prophylaxis and/or IVIG transfusions while awaiting a stem cell transplant. The last important point to remember about patients with SCID is that clinicians should avoid the use of live vaccines in these patients due to their weak to non-existent immune systems. Similarly, giving these patients inactivated vaccines will not be effective either, as their immune system will not be able to mount an appropriate response. What are the similarities and differences in clinical presentation of severe combined immunodeficiency and HIV in infancy? Both severe combined immunodeficiency and HIV in infancy will have several clinical features in common. Those include chronic diarrhea, failure to thrive, and opportunistic infections, most commonly with pneumocystis or Candida. There are two clinical differences between these conditions. First, babies with severe combined immunodeficiency will have lymphopenia, whereas babies with HIV in infancy will have a normal absolute lymphocyte count, but a low CD4 T cell count. Second, patients with SCID will have no lymphadenopathy or hepatosplenomegaly, whereas babies with HIV in infancy will likely have lymphadenopathy and potentially hepatosplenomegaly. Remembering these key differences should help you confidently distinguish these two similar presenting pathologies on exams. Now that we've covered severe combined immunodeficiency, let's move on to discuss Wiskott Aldrich syndrome. At its core, Wiskott Aldrich syndrome is a primary immunodeficiency disorder that affects leukocytes and platelets. Specifically, an X-linked recessive mutation in WAS gene impairs cytoskeleton remodeling or regulation of leukocytes and platelets, which in turn impairs the function of these cells. The primary risk factor for Wiskott Aldrich syndrome is male sex, due to its X-linked recessive inheritance pattern. This disorder usually presents early in infancy with the classic triad of recurrent infections, eczema, and microthrombocytopenia, which may manifest in the form of bleeding, easy bruising, or petechia and purpura. Once again, these clinical features stem from abnormal cytoskeletal remodeling within lymphocytes and platelets. Here's an image of eczema that may be seen in patients with Wiskott Aldrich syndrome. Note its characteristic erythematous appearance on the forearms and wrists. Here's an image of petechia and purpura that may manifest in patients with thrombocytopenia. Note these characteristic erythematous dots and circles over the patient's skin. Notably, petechia and purpura do not blanch with pressure. The diagnosis is usually first suggested on a CBC, which will reveal thrombocytopenia and potentially lymphopenia. Clinicians may obtain a quantitative serum immunoglobulin measurement, which may reveal elevated levels of IgA and IgE and decreased levels of IgG and IgM. It is unclear why this change in immunoglobulin concentrations occurs, and not every patient may have this pattern of immunoglobulin levels. Once the clinical suspicion for the diagnosis is high, genetic testing may confirm the diagnosis by revealing a mutation in the WAS gene. Importantly, among all laboratory findings, thrombocytopenia appears to be the most consistent finding from one patient with Wiskott Aldrich syndrome to another. As far as management is concerned, Wiskott Aldrich syndrome is treated with a stem cell transplant. What is the triad of clinical features often seen in patients with Wiskott Aldrich syndrome? The classic triad of clinical features seen in patients with Wiskott Aldrich syndrome is recurrent infections, eczema, and microthrombocytopenia. It is worthwhile to reinforce this point because examiners tend to point out this diagnosis in question stems using this clinical triad alone. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing the congenital mixed immunodeficiencies before your exams. Let's conclude this lecture with a multiple-choice question. A 4-month-old girl is brought to the pediatrician by her mom because of a white rash on her tongue. The girl's medical history is notable for chronic diarrhea, multiple episodes of otitis media, and a prior hospitalization for pneumonia. Temperature is 37 degrees Celsius, and a pulse is 100. The girl is at the second percentile for weight. Physical exam is notable for white, fluffy lesions on the girl's tongue that can be scraped off with the tongue depressor. There are no visible tonsils and the lymph nodes are not palpable. Laboratory evaluation reveals a decreased absolute lymphocyte count and decreased serum levels of all immunoglobulins. Which of the following additional findings would be consistent with this patient's most likely underlying diagnosis? A. Elevated alpha-fetoprotein. B. Thrombocytopenia. C. Absent thymic shadow on chest X-ray. D. A history of eczema. E. Absent CD40 ligand on flow cytometry. F. A positive HIV test. The correct answer is C, absent thymic shadow on chest x-ray. This is a case of a 4-month-old girl who's brought to the pediatrician with white rash on her tongue, which can be scraped off with a tongue depressor. This should instantly raise suspicion for oral thrush, which in turn should raise suspicion for a congenital immunodeficiency, especially given the history of chronic diarrhea, multiple episodes of otitis media, a prior hospitalization for pneumonia, and failure to thrive. Furthermore, this girl's physical exam shows no visible tonsils and no palpable lymph nodes, and her lab evaluation reveals a decrease in absolute lymphocyte count and all immunoglobulins. Putting all these clues together, this girl's most likely underlying diagnosis is severe combined immunodeficiency. Recall from this slide that the clinical features of severe combined immunodeficiency include recurrent viral, fungal, and opportunistic infections that start by age 6 months, chronic diarrhea, failure to thrive, and scant lymph tissue on physical exam, such as absent tonsils or palpable lymph nodes. The patient in question had all of these clinical features. Next, recall from this slide that one of the key diagnostic features of severe combined immunodeficiency is the absence of a thymic shadow on chest x-ray. This is why option C, absent thymic shadow on chest x-ray, is the correct answer. Option A, elevated alpha-fetoprotein, is not seen in patients with SCID. Rather, it can be seen in patients with ataxia-telangiectasia syndrome. Option B, thrombocytopenia, and option D, a history of eczema, are both clinical features of Wiskott Aldrich syndrome, which is unlikely in this clinical vignette. First, Wiskott Aldrich syndrome is X-linked recessive and therefore more commonly seen in boys than in girls. Second, this patient does not have any clinical features that would indicate thrombocytopenia, such as petechia, purpura, and history of bleeding or easy bruising. And third, absence of tonsils and palpable lymph nodes is not a common clinical feature of Wiskott Aldrich syndrome. Option E, absent CD40 ligand on flow cytometry, is a feature of hyper-IgM syndrome, not SCID. Hyper-IgM syndrome is unlikely in this patient because her lab evaluation revealed decreased levels of all immunoglobulins. Patients with hyper-IgM syndrome would have elevated levels of IgM. Lastly, option F, a positive HIV test, may be a tempting option given how similar HIV in infancy presents to SCID. However, as mentioned earlier in this presentation, infants with HIV usually have lymphadenopathy and potentially hepatosplenomegaly, rather than an absent or scant lymph tissue. And this concludes our lecture on congenital mixed immunodeficiencies.